Hey, Esophageal Diverticulitis. This is covering upper GI again, part 2, I guess. Alright, so diverticulum is a sac or a pouch in one or more of the layers of an organ or a structure. So here in this picture, you can see the most common kind is the Sinker's diverticulum. And typically, it's going to affect men more than it will women. But basically, it occurs at the pharyngeal, esophageal juncture, and it just creates a little pouch. Problem is, with this pouch, food can get trapped back there. It can be congenital or it can be an acquired weakness, but it's just that little pouch right there. Signs and symptoms, the first one is going to be foul breath. So food gets trapped back there and they have really bad breath. They could have pain, difficulty when swallowing, belching, regurgitating, coughing. The barium swallow evaluation, they drink the barium, they do an x-ray. It's going to show these structural abnormalities, and that will be a definite diagnosis for us. Treatment and nursing, we are going to teach them that oral hygiene is not going to fix their bad breath. They have to modify their diet. And so with that diet, we're going to encourage them to do bland, soft diet. Helps just facilitate easier passage of food, eating small meals a day, 4 to 6 small meals a day, more soft diet, liquid diet, something like that. They may actually have to go in and do surgery, and that just kind of depends on case-by-case scenarios. But they need to know that they have to change their diet. Doesn't matter how many times you brush. If food is trapped back there, it's not going to help your breath. A hiatal hernia. This is where a portion of the stomach protrudes through the weakened area in the diaphragm. So here's a picture of it. And you can see part of the stomach is pushing through into this esophagus past this diaphragm right here. Okay, so it's just a weakened area in the diaphragm. You can have different types. Sliding axle is pretty common. And the junction of the stomach and the esophagus just kind of slide in and out through that weakened portion of the diaphragm. You can have paraesophageal, the fundus is displaced upwards through the diaphragm. So right here, this fundus part goes on through the diaphragm right there. With it, patho is usually just a congenital weakness. It can be increased abdomen pressure, trauma, relaxation of the musculature. It's often common in women, especially like with pregnancies. Multiple pregnancy puts them at higher risk. Just more abdomen pressure up there, of course. Obesity will do the same thing. And then losing muscle. If that muscle is weak, then it's more likely that a portion of that stomach can push on through the wall of it. For diagnostics, we're going to do an upper GI series. They'll swallow the barium, and you'll watch it on x-ray. You'll actually see that barium going down through the esophagus. But in this situation, you're going to see that hiatal hernia come up. They can also do a scope and look through with an EGD and scope them. Or they can do a chest x-ray, and again, it's just going to show that hiatal hernia right there. Signs and symptoms are going to be very similar to the GERD. You're going to have heartburn, epigastric pain, reflux, especially with the sliding hernia, dysphagia, and difficulty breathing as well. Treatment is going to be the same as those GERD guidelines, so you're going to give them over-the-counter acids to try and kind of keep that reflux and that heartburn down. H2 antagonist and proton pump inhibitor, as well as just avoiding those foods that cause the heartburn and things to be more difficult. Of course, if that doesn't work, they would do surgery on it as well. Esophageal cancer, this has a very strong correlation between chronic alcohol use and cigarette smoking. The cigarette smoking, the chronic alcohol use, it basically just tears down the mucosis in that esophagus. A history of GERD will also predispose them to these adenocarcinomas, those cancer cells there. Again, it's just breaking down that tissue. Affects men more than women, usually diagnosed around 40s or 50s, and oftentimes it's going to start presenting as a tumor. So what you'll see is that the patient will come in, they'll have difficulty swallowing, difficulty chewing. They'll have some weight loss. And if it's real late, they can only swallow liquids. They're not able to take any foods. They'll have regurgitation and even blood loss. Typically, we do see that it develops kind of slowly. Treatment is going to be surgery, radiation, and chemotherapy, and usually a combination of those three. We want to go in, we want to do surgery to remove that tumor, whatever it is, those adenocarcinomas, those bad cancerous cells. We want to go in, we want to remove them, and then we want to treat that spot, that same spot. We want to go all around it and treat it with radiation and just kind of kill any of those cells and make sure with chemotherapy that there aren't any other cells that spread throughout the body. So it's kind of, you can almost think of a chemotherapy as the shower, the radiation as going directly to that spot, and the surgery is just removing that spot, removing that tumor. With esophageal cancer, surgical procedure is going to be resecting that tumor from the esophagus. So you can see three different pictures here. Obviously, the stomach is still intact in this one. Here's the cancer, and so we have to remove that cancer and reconnect the esophagus to the stomach, or sometimes we're not able to save much of the stomach and we connect it right straight to the jejunum. Just depending on how extensive the cancer is, that's kind of what resection they end up doing. Nutrition-wise, they're going to be on TPN and tube feedings. It may be necessary, and usually it's going to be. They might even go ahead and place a G-tube just to facilitate eating a lot easier. Sometimes they can be very sore and just don't want to eat, so a G-tube helps them with that. But they've got to get the nutrition in, and so we got to be on top of that as well. Gastritis is going to be the inflammation of the mucosal lining in the stomach. So you have that mucosal lining, which actually helps just protect the stomach from all the acid. You know, and the acid is what breaks down the food. You have that lining in the stomach to protect from that acid just eating through your stomach. But with this, there is an inflammation in there. There is some kind of infection in there, and so it's trying to eat away at that lining. Acute gastritis can be caused by indigestion of irritants. It could be aspirin-related, alcohol, caffeine, some kind of bacteria in contaminated food, like food poisoning, toxins, trauma, surgery, shock. All of those are going to cause acute gastritis. And acute, of course, we know it means short-term, right? Irritation, inflammation, superficial erosion, mucosa rapidly regenerates and it heals within days. So a lot of times whenever you have food poisoning, although it's horrible and it feels like it lasts forever, you typically get over it within a few days, and that's kind of how acute gastritis works. That mucosa will rapidly regenerate, fix itself, and you'll go on. However, with chronic gastritis, it's progressive and the changes to the stomach wall are irreversible. Typically, this happens in the elderly, the alcoholics, and those cigarette smokers. H. pylori can contribute to it as well, and H. pylori we learned is a very bad bacteria that lives there in the gut. It is actually in most people. Most people it doesn't affect. Whenever it does strike up and become bad, though, it becomes very, very bad and can really do damage to your stomach. Toxins such as lead can also attribute to occurrences in this. So basically, the parietal cells in the stomach increase acid production in response to seeing, smelling, and eating food. So when you take in that food, parietal cells start creating acid so they can break down that food. With this, however, a parasympathetic vagus nerve stimulates the parietal cells by releasing histamine and anticholine, which again breaks down that food. Extra gastric acids breaking down that food. All of this is going to produce that strong acid, strong enough to actually start eating away at the stomach lining. So gastritis, it's eating that stomach lining. Signs and symptoms, anorexia. When you feel that bad, your stomach's hurting that bad, you just don't want to eat. You'll have nausea, vomiting, abdomen pain, discomfort, indigestion. It might even be bleeding. That lining might be so inflamed that it bleeds and causes you to cough up blood. Melena, remember, is the tarry stool, so that means that you are bleeding and it's actually coming out in your stool. It'll look like black tar. Black, of course, we know is old bleeding. Anemia. It does put you at risk for pernicious anemia, and that is related to the inhibition or the blocking of that intrinsic factor. The intrinsic factor is what helps aid in absorption of B12. The B12, of course, helps with production of your red blood cells. So you could actually see anemia with this. Diagnostics, we're going to do an H&H, an endoscope, guac stool studies to show and see if there's any kind of blood in the stool. Treatment, NPO, if experiencing persistent vomiting. And of course, if anyone's vomiting, we're not trying to give them food or water or drinks or anything like that. We're going to give them IV fluids and make them NPO. You want to reduce the stress, and antiemetics help them to not throw up so much. Let's give them an antiemetic. And antibiotics if it's bacterial. If it's H. pylori, then we're going to be giving them antibiotics. But of course, that depends on the cause. So when the symptoms start subsiding, we're going to avoid any kind of insects because that's only going to make that gastritis worse, that lining. It will eat at the lining. Alcohol, smoking, the same thing. It's bad on that mucosal lining. They may have to avoid spicy foods, and they may need to take some antacids just to help bring down that acid, suppress that acid in the stomach. Peptic ulcer disease, or PUD we can call it, is ulcerations in the mucosal lining of the distal esophagus, the stomach, the small intestine, duodenum, or the jejunum. And it can extend deep into the tissue and all the way through to the peritoneum, which, remember, is the sac surrounding those stomach contents. It occurs in areas that are exposed to hydrochloric acid. Of course, we know the hydrochloric acid is what breaks down the food. However, it can eat at the lining too. Gastric secretions, very highly acidic, and it causes damage to the mucosal lining of the stomach from whatever. It can be caused from gastritis, which we just talked about, from different foods, different drugs, anything that allows those gastric secretions to start eating away at that stomach lining. Okay, instead of the gastric secretions eating away at the food like it's supposed to, now it's attacking you, it's attacking your stomach lining. The cells in the stomach lining are damaged, and when these damaged cells, when they get damaged, they start releasing histamine. Histamine is what helps break down the food. Histamine triggers the secretion of even more hydrochloric acid and pepsin, so we're building up more acid. And with that acid, all that extra acid, it is attacking our cells. And so now the mucosal liner is weaker, it's swelling, it's bleeding, and it's just really, really inflamed. The food comes in, you might try and eat something, and all of a sudden that pain is gone. It just helps. It relieves that pain. Well, the food causes acid production, so eventually more acid is going to be in your stomach. Although you ate and it felt good for a second, because of that food, we're creating more acid. More acid is, of course, going to affect that ulcer, eat away at that ulcer, and cause more pain. So it's just kind of a vicious cycle that goes back and forth. And so when you're thinking of peptic ulcer disease, that is one of those triggering things. They eat and the pain goes away. So remember that. If the patient is having back pain, it does suggest that it's irritating the pancreas. So we want to watch out for that. So here's a picture of it. You can see big peptic ulcer right there, just eating away through that lining. And of course, you pour acid on that. That's going to hurt. It's the same concept if you have an open wound and you pour hydrogen peroxide on it. It fizzles up and it hurts sometimes. Okay. So pouring acid on that, we don't want to pour acid on that. You don't want to pour acid on an open wound. It will hurt. But that's what peptic ulcer disease kind of is. So caused by oftentimes H. pylori. Remember, H. pylori is that bacterial lives in the gut, but eventually it starts eating away. If it flames up, it can eat away and cause really bad peptic ulcer disease. Chronic use of aspirin, NSAIDs, cigarette smoking, stress, alcoholism, those can all cause peptic ulcer disease as well. History of chronic gastritis. Okay, remember there's acute, and then there's chronic gastritis. So chronic gastritis can also cause peptic ulcer disease. Physiological stress, burns, Cushing's ulcers, shock, sepsis, trauma, increased ICP, Curling's ulcer. All of these things are diseases that you can see in the hospital, and that is why we put everybody who comes into the hospital on a proton pump inhibitor as soon as they come in to hopefully prevent these ulcers. And signs and symptoms: epigastric pain, gnawing, burning, aching, hunger-like, just horrible, horrible pain in your stomach. Often occurs when the stomach is empty. Like we said, it's relieved by eating, feels better, but only temporary because of that food. It's going to build up more acid, and it's just going to cause the pain to come back even worse. It may radiate to the back, and we said that oftentimes means that it's going towards that pancreas even. Heartburn, regurgitation, vomiting, weight loss, anemia, melena. Okay, you can also have pernicious anemia, hemorrhaging, occult or frank in the stool, throwing up blood, fatigue, weakness, dizziness, orthostatic hypotension, shock, obstruction, all caused by edema, inflammation, feeling of fullness, nausea, vomiting. So it can even go to where it is an obstruction. So that's something to watch out for. Mucosal lining of the stomach produces the intrinsic factor, which is needed to absorb the vitamin B12. Chronic inflammation is going to inhibit that production, and poor or no absorption of vitamin B12 means that it's going to lead to pernicious anemia, and so that patient is going to become anemic. With the hemorrhaging, it results from ulceration and erosion into those blood vessels of that gastric mucosal. The erosion can basically erode into those small blood vessels, cause some slow bleeding, long bleeding. It's going to cause those black tarry stools. Erosion into a larger vessel can cause sudden severe bleeding with hematemesis or red blood with clots in the stool and signs of shock. So it can definitely cause hemorrhaging, which is going to be life-threatening. It can also cause anemia, which is not good either. Complications: perforated ulcers. So this is going to be the most dangerous complication, and that's basically the hole forms into the gastric lining. It goes all the way through. Gastric contents enter the perineum, into the abdomen cavity, and it will cause inflammation and peritonitis, inflammation of that peritoneal, that sac that surrounds all of the gastric contents. This is going to cause severe upper abdomen pain radiating to the shoulder. A lot of times that's going to be called referred pain. Rigid board-like abdomen, meaning that there's probably bleeding in the abdomen as well. Absent bowel sounds, you will not be hearing anything. Even if you listen to each quadrant for 5 minutes, 20 minutes total, absent bowel sounds, you won't hear a thing. Signs of shock: diaphoresis, tachycardia, rapid and shallow respirations, and fever. And of course, shock is life-threatening. Anytime you see tachycardia, the heart rate is going to be going up, blood pressure is going to be going down. Those are your signs and symptoms, your classic signs for shock. Okay, so with peptic ulcer disease, diagnostic, a lot of times they come in and it's history of signs and symptoms. They tell you that the pain is horrible, but it's better with eating. As soon as they finish eating, it gets worse. Of course, we know that is kind of a classic sign and symptom for peptic ulcer disease. We will do an upper GI series. We might do an EGD and actually visualize that ulcer. We'll run some tests for H. pylori and see if that's the cause of it. Of course, with H. pylori, we're going to treat them with some antibiotics. We'll do a CBC as well. We'll look at their red blood cell counts and see if they're anemic at all. Treatment: avoid foods that increase that gastric acid. So milk products, alcohol, caffeinated beverages, even decaf coffee, all of those things are going to increase that gastric production in the stomach and going to cause this problem to be even worse. We're going to encourage small, frequent meals. We're going to treat them with H2 antagonists. And remember, the H2 antagonists, it ends in DINE. So you can see all of those. And then PPIs, proton pump inhibitors. Those are going to end in the ZOLs, ZOLEs. Okay? Both H2 and PPIs are going to inhibit the gastric acid production, bring it back down. Carafate is a new drug that we haven't talked about yet, sulcrafate. It is a cytoprotective agent, and basically what it does is it's kind of like a patch over that ulcer. It's just going to go in and it is going to seal that lining off, okay? Patching a hole in a tire, sealing it off. So you have a big ulcer, it's sealing it off, going right over it. Of course, if it's H. pylori, we're going to treat them with a combination of antibiotics, the proton pump inhibitors, bismuth salts, some flagyl or metronidazole, and then just hopefully heal that mucus lining. If it's an obstruction, we're going to do meds, and we're going to do an NG tube, help relieve that pressure. So that's where NG tubes come in to decompress. Sometimes we feed with them, sometimes we decompress the stomach. Obstructions, we're decompressing the stomach. If it's hemorrhaging, we're going to put them on complete bed rest. We're going to be pushing IV fluids. We're going to be doing blood transfusions. Okay, this is real serious GI bleeds. They can go bad really, really quickly. So we might even be doing some gastric lavage on a GI bleed as well. And GI bleeds are kind of smelly too. They can be real serious real fast. If it's perforated, this needs immediate intervention. We're going to make the client NPO. We're going to give them IV fluids, NG to suction, antibiotics, and they will be taken immediately to surgery. Okay, we're going to stop right here for stomach cancer, and we will pick up next time.